Great. Lovely.
All right, you're on the first image.
Okay, so we have a color fundus photo of the right eye. The media looks clear. Nerve looks pretty sharp, well defined. The vessels look within normal limits. The macula otherwise looks pretty kind of unremarkable. I think this is a pretty unremarkable color fundus photo of the right eye.
You zoom in a little bit so people can learn. These eyes.
Dot plot hemorrhages and like area of like a little hyperpigmentation kind of scattered.
Okay, yeah, this wolf plots, maybe mention them as well. And yeah, you got the dot plots and yeah, maybe talk a little more about the pigmented lesions.
Just like off kind of beyond, the arcades, they just kind of look to be maybe like subretinal, like within the choroid here, kind of speckled appearance scattered throughout.
Yeah.
So this is a color fundus photo of the right eye. Again, the media looks clear. The left eye, sorry. The nerve looks otherwise kind of unremarkable. Hypertrophy macula.
I think we'll zoom in again.
Yeah. Again, have similar appearance with the a few like dot plot hemorrhages and then the areas of kind of hyperpigmentation throughout, very similar to the right eye.
Good.
So an OCT of the right eye, the foveal contour looks good. The layers look well organized. There doesn't seem to be any disruption of the layers. Looks like a pretty unremarkable. We have like a.
Yeah, maybe like one family in there or something.
What do you think that is? Do you know what that is? That's sort of a funny looking lesion. That's that white spot, the little rectangle there.
Could it be like a little like a exudative like area?
Probably. I mean, that's a vessel. Yeah, it's a vessel. You get these funny, if you cut a vessel, if you don't like nail a vessel, you get this funny looking white line on your OCT, which can be very like, so you look at it like, oh my God, what's that? It's like, oh, it's just a vessel.
Okay, so we have an OCT of the left eye now. Again, the foveal contour looks pretty well preserved. It's just the retinal layers. Looks pretty unremarkable here. And then this is an autofluorescence of the right eye. I think it corresponds to these areas of hypoautofluorescence that we saw in the color from this photo. And also of the left eye, kind of a similar appearance. So we have an FA of the right eye. There appears to be areas of hypofluorescence, kind of corresponding to maybe like blockage in these areas. I think where the hyperpigmented areas were before.
I have to say that one on the below the nerve, I think the ones on top are different from the one below the nerve.
This one.
Yeah, so there's two causes of hypofluorescence, right? One's blockage, what's the other one?
There's blockage and there's if it doesn't fill.
Yeah, so non-perfusion. So that could be blockage or non-perfusion. The other ones are blockage from the thing, but that could be a little area non-perfusion. I think that might be where the commonwealth well is.
And it seems like a kind of a late photo, maybe areas of leakage around the area of the cottonwool spot here, but then you see again these hypofluorescent areas.
Yeah.
And similar appearance of the left eye FA. Again, the area of hypofluorescence. Maybe some areas of hyperfluorescence here and here. So, kind of leakage around.
So it's interesting, all the leakage when the OCT looks normal, right?
Mhm.
So how do you think that can be?
Mm. Could be related to. Mm, backwards.
Well, you could have leakage without, if you have leakage without swelling, it just means that the body's keeping, it's either leaking into the vitreous or the body's keeping up. So the fluid's leaking out, but the body's absorbing it, so it's not, you're not getting swell, you're getting leakage all over the place, but not. That's one of the problems with the OCTs. The OCTs aren't that functional. I mean, they're not, they don't show you leakage because you can't really tell by, sometimes there'll be leakage without swelling. When we got our OCTs, I don't know what it was like for you, but I was shocked that some of the patients the OCT looked totally different from what I thought. Because you get a fluorescein like this and you think there was swelling and maybe doing laser and everything, and then you get the OCT and there's like absolutely no swelling. It was just remarkable how, and no other people where the fluorescein showed nothing and the OCT showed this giant fat retina. The disconnect between fluorescein and OCT is interesting.
Okay, so, Dr. Cohen kind of asked me to disregard that direct portion of it. So just sort of focusing on.
And this is Dr. Fowler's case, I think, just to give him credit.
Kind of focusing more on the pigmented areas. We did see the scattered clusters of darkly pigmented lesions bilaterally. As you noted, they're hypoautofluorescent on the FAF and hypofluorescent on the FA. And for those lesions in particular, the differential.
They could just be kind of like, several like scattered nevi, the clustering be related to like CHRPEs.
Yeah.
I think we talked about like malignancy before, but
Yeah.
more atypical.
A laser spot, too, for that differential.
Like cobblestoning, something like that. All right, so you got most of them there, nice. So yeah, CHRPE, or colloquially called bear tracks, we'll get into, it actually is CHRPE. But choroidal nevi, as you said, and BDUMP is a hernioplastic, rare disorder, but it can cause, like diffuse pigment lesions bilaterally, potentially. Cobblestones, reactive RPE hypertrophy, so that would be like a laser spot or inflammation or any various mechanisms. And then maybe even like a sunburst lesion and sickle cell retinal. Good job there. So again, yet the diagnosis is CHRPE, which actually Albert had mentioned just the case before. It's got to always be on your list of darkly pigmented lesions. And so CHRPE is short for congenital hypertrophy of the RPE. But generally you're gonna have these round, almost universally flat pigmented lesions. The colors can vary a bit from like a lighter gray to very dark, like you see in that first example, a dark brown or dark black. They tend to have pretty sharply demarcated borders, which can be described as smooth or scalloped as well. And then important features, they'll often over time develop these kind of punched out lacunae, which is actually like a depigmentation within the pigmentation. So actually there it looks more lightly colored, compared to the rest of the lesion, compared to the rest of the retina. They tend to be more peripheral and equatorial, not necessarily always. I'll show some examples in a moment. Here again are the lacunae, the depigmented areas. Later it can really look almost entirely depigmented at that stage there. And then it's important to note there are three sort of forms or varieties of CHRPE. By far the most common, which is why I started with these photos, is the solitary form. So when you're considering, like in Albert's case earlier, like between nevi and melanoma, CHRPE would be on there, a solitary CHRPE. And then we have the group, which we'll get into in just a moment, and then atypical, which are the more concerning ones to look out for. Here's an example of one actually right around the nerve, which is not often common, but you might think of like the melanocytoma when you first see a dark lesion there, but again, if you look at those lacunae, that can be a good sign that you may be dealing with a CHRPE lesion. And when it's solitary, they're generally benign. Now talking about the grouped CHRPE, multifocal lesions is what we had in this case. So they, when they're scattered like this, they can look like animal footprints, so they were colloquially termed bear tracks. Here's an example of an actual bear track, along the CHRPEs. And usually they're gonna be unilateral when they're multifocal, unilateral when they're a group like this, but actually in our case, we had it bilaterally. And then you'll notice, there's some more photos of some examples of these bear track or grouped CHRPEs. You may notice that they don't tend to have the lacunae as frequently, so less of those punched out areas. And then they tend to be just in one quadrant of one eye. Like I said, it can be bilateral, as we saw in our case, or they can be more multifocal. So you see that bottom right one has basically lesions in every quadrant. And then the third type here is atypical. And this is where you're thinking and you're concerned about certain systemic conditions. So an atypical feature is, again, any time there's multiple lesions. When it's bilateral, that's concerning. And then the size and shape of these are characteristically more irregular, less round, kind of more of this fishtail or teardrop shape. Tend to be a little bit smaller than your typical benign CHRPE, solitary, or even those bear track grouped lesions. And then they may have a little depigmented halo kind of around parts of the lesion, which you can maybe appreciate those images and those examples there. So in FAF, like we noted, these CHRPE-like lesions will be hypoautofluorescent, and that's due to high melanin content within the RPE. FA shows no leakage. They typically block underlying choroidal fluorescence, except unless you have lacunae or halos around or within the lesions. And we noted that these are the exact images from our case. So you see the hypoautofluorescence top left, and then bottom left, you can make out again some of that hypofluorescence of those peripheral spots. And then OCT, not particularly instructive because basically the RP can be a little bit thickened, it can be a little irregular. And then this is actually showing in an area of lacunae, those dotted lines. You get kind of, I guess it's like a hypertransmission effect there, shine through where the RP has a break. The RP is absent in those areas of lacunae. Okay, so the important connection here is with Gardner syndrome. Go back to the first couple years of medical school. This is a variant of familial adenomatous polyposis, FAP, which basically universally patients develop hundreds of tumors by the time of 30 to 40, like malignant tumors of the GI tract. Gardner is a specific variant of familial adenomatous polyposis, wherein there's atypical CHRPEs plus the FAP syndrome or disorder. This is an autosomal dominant inherited trait. And in these cases, or in this subtype of FAP, the large majority do have CHRPE. This is important because it can actually be the first clinical indicator of this specific subtype of FAP, Gardner syndrome. So you don't want to ignore this. It's actually, speaking of worst case scenario, it's gonna be life-saving for you, David. And then also 20% of the time there's you pass it on. 50% of offspring of a person who has this disorder will pass it on. However, it can also develop de novo. 1 in 5 patients will have a sudden mutation in that APC gene that ends up in this type of syndrome. So that's important to note as well. They don't have to have a strong family history, although most of the time they would. And then another subtype of FAP to know about for our purposes is called CHRPE syndrome. This is where you have FAP and CHRPE, and also brain tumors of different varieties. So turco, turban, is the mnemonic, turbans on your head, it's like a brain tumor there. Let's talk a bit about the management. So, for most CHRPE lesions, which as I mentioned, are mostly going to be these solitary benign lesions, with not with unconcerning features. These you just monitor. They do tend to grow a bit over time, especially the first few years. And then, as I also mentioned, they start to have a depigmentation pattern where there's lacunae or even fully depigmented, like in that photo there. 1% of these can also undergo malignant transformation. That's why we observe and watch them. In general, the vision is not really affected in most cases, unless in the rare case it is in the fovea, but mostly it's peripheral. This is actually a pretty interesting example where there's CHRPE like around the nerve and the macular, that's pretty uncommon. And then if you have any of those atypical features, or there's multiple, that's when you're considering to pursue a systemic evaluation and, get a good strong family history, to exclude or potentially identify, a patient with this, FAP disorder. And then if CHRPE is associated with the FAP, then this ends up being a, multidisciplinary approach needed, with the GI team, colorectal surgeons. Most of these patients end up having, electively, have their GI tract taken out, and that actually can save their life. And they still develop tumors in other areas, but it's generally the GI tumors that are the most life-threatening. So again, another way you can do a lot of good for the person if you recognize this early for them. That's pretty much it. Oh, and here's just if you want to hear the map of all the bear sightings in Florida. If you see bear tracks, don't ignore them.
There was actually a death recently.
Was there
Oh,
bear
really?
death?
Yeah, there were three, they think there were more than one bear and they killed a man and his dog. I don't know where, but it was very recent. Now you're retired, you hear all these weird things.
That was very, Mathias, that was
There's a
excellent.
rule for bears too, it's brown, you lay down, it's right back, white, say goodnight.